This is Action Potential. I'm your host, Sahan Ranamukarachi, and we welcome you to the show. Our goal is to propagate ideas that can revolutionize medical care delivery. Join us on a transformative journey as we amplify the voices of thought leaders, explore the cutting edge of remote physiological monitoring, and ignite a wave of positive change.
Hi, everyone. This is podcast episode 3 of the Action Potential podcast. I'm so delighted to welcome Dr. Shaminder Gupta from Monogram Healthcare. Dr. Gupta and I have known each other for a while now, and we've often spoken about the topic of remote physiological monitoring, better care at home, how to manage chronic populations earlier. Lots of different interesting topics for us to discuss and dig into today, but we're delighted to have him join our podcast. And without further ado, Dr. Gupta, who I refer to as Shami, and so Shami, please introduce yourself to our audience and tell us about your journey.
Yeah, thank you, Sahan, for the invitation today. Really excited to be here and share this experience. So Shaminder, Shami Gupta, I'm a nephrologist, born and raised in Louisiana. My parents are of Indian origin, but immigrated in the 60s to America, and landed in Louisiana. So basically, born and raised here, did my training here at LSU Medical School and my residency and fellowship at Charity Hospital in New Orleans, and was fortunate enough to finish right before Hurricane Katrina. So finished my training in 2004, which also helped shape my career. As I left training, I imagine, like most nephrologists, finishing training, not really knowing what was ahead of me, but I had a very big interest in academics and teaching and being part of residency programs. So I envisioned my career would take that path of being a part of the university and teaching and doing dialysis and all those things that nephrologists do. Immediately impacted by Hurricane Katrina 1 year later, as I was in a private practice I didn't enjoy, went back to academics part-time, and then the hospitals I was practicing both flooded during the storm. So I went from being employed fully to being unemployed fully overnight with a young family and a lot of uncertainty. Fortunately, I used to work nights at a small hospital, moonlighting like a lot of residents did at that time. And I was able to land a job there in a small town called Houma, Louisiana, just southwest of New Orleans, very rural community, and loved it because I grew up in a town that size prior to moving to New Orleans, and thought it'd be temporary, and ended up going there and loving it, and built my practice career there, teaching residents, building a residency program, but also having the ability to do nephrology and some entrepreneurial things that other nephrologists didn't have the opportunity to do because of the rural market. Fast forward 5, 6, 7 years, built a home dialysis program before it became in vogue in 2008, 9, and 10, really out of necessity because of the hurricane and the weather threats here. And I was a new nephrologist, not really understanding what that meant, but just started building, getting some mentorship, building this practice. And in 2011, launched my own joint venture dialysis clinic with a small company called Reliant Renal Care, competing with the LDOs like Fresenius and DaVita in my own market. And, if you can't beat them, join them was the philosophy, really. As 6 years passed and I'm duking it out with them, eventually Fresenius acquired Reliant Renal Care and allowed me to stick around as medical director. All the while, Sahan, serving my community as the National Kidney Foundation president, having some other entrepreneurial ambitions, and lo and behold, met Monogram Health as they launched their business model in Louisiana and the Gulf states through Humana in 2019. VBC, they called it. I was already practicing it. So the CEO and I hit it off, and a good time of life for me as my children were growing up. I was tired of working nights and weekends, and I wanted to test the waters with this. So hence, I'm now the chief medical officer of Monogram, and I've done that role now for the last 2.5 years, and really enjoying bringing that local model that I launched in my community to a much grander stage. We're in 35 states now, managing nearly 110,000 lives from CKD3B through end-stage kidney disease, and really in this very holistic approach, which I'm very excited to share with you today.
That's amazing history of your practice and your journey to get to where you are today. Shami, tell us a little bit about Monogram's journey as well, and then we can dig into a little bit of the influences that you just mentioned of your own career to the type of things that you're doing right now with Monogram. Monogram, from what we see, is a massive company now that's growing ever so rapidly. Some key investors backing you, along with other players in the kidney care space.
Yeah.
What's really the driver behind Monogram's growth since, like you said, 2019 wasn't a long time ago.
Right.
There was COVID in between that, yet people are increasingly starting to recognize the work you're doing at Monogram, and that must be really rewarding. So tell us a little bit about Monogram itself.
Yeah, so when I joined Monogram, the model was really a managed services model where we would partner with practices and existing PCPs, nephrologists to drive better care through evidence-based guidelines. We didn't manage our own patients, but we helped manage large cohorts of patients through a payer, for example, Humana, Cigna, and others. As we started doing that, we realized that a lot of the patients we were seeing, basically through claims data, did not even know they had chronic kidney disease. Hence, they had not even been referred to a nephrologist, and we were often the first person telling them that they had kidney disease, which was obviously very disconcerting to the patient. So after that, we found that out. The health plans really asked that we start providing some of the care to the patients through diagnosis capture, and then following that with really an innovative way to see patients in the home using our own care team. So we evolved from a managed services company to a full-scale provider now over the last 4 years through demands. And as you mentioned, COVID really accelerated this, as we're one of the few companies in the country and the only one in the VBC kidney space that actually deploys an in-home model. So we are comprised of an MD leading a pod who leads an RN, social worker, dietitian, our own internal pharmacy department, and SDOH departments. And we deploy what the patient needs at home, whether they have an existing care team, meaning PCP nephrologist, or they don't. And we are not directly involved in terms of their care if they have a doctor, other than being the eyes and ears of the practitioners in the field. So the thought is that if they have an extra layer of care, they'll call before they go to the hospital for things that can be taken care of outpatient. We work to drive better outcomes in terms of planned dialysis, starch transplant, and conservative care. But our journey has been a rapid one because of the needs and demands and the real boom of value-based care across the country. I'm very happy that we have competitors in our space all pushing each other to drive patient-centered care. Nephrology was a very fragmented, siloed care system before. Patients were GFR-based referrals, and then they had a cardiologist and endocrinologist, et cetera. Now we're kind of refocusing that care to a one-stop shop or a centralized service and utilizing the specialists the patient needs, not utilizing all the specialists that are available. So really empowering upstream care really became the name of the game. And from a patient-centered way, it makes sense. Obviously, the patient is at the center of this. They're being taken care of the way they need to be. But from a payer point of view, it also made sense, right? Because it avoided overutilization. It created accountability. And dialysis no longer becomes a default when you think that way. It becomes an option, which is one of our theses at Monogram, that ESKD should not be synonymous with dialysis. So a lot of the private equity and backers also, recognize this opportunity, as you alluded to in the intro. And there's been a lot of support of not only us, but other VBC-based renal companies across the country. So we're no longer VBC renal, we're VBC polychronic. So we've really expanded our services to touch on realizing that patients don't only have one illness, they often have concomitant cardiac disease, diabetes, COPD. And most importantly, I think, as social determinants of health and behavioral health issues are often ignored or undertreated because people just don't have the capability of doing that. So we emphasize that approach to all 5 domains, really, of the patient.
Is this kind of your dream job, Shami, having worked in home dialysis in rural communities where you probably saw, a lot of the reasons why people ended up in dialysis and thinking, upstream and thinking, how do we stop that from happening? And now having the capability to really make that kind of, the dots connect in a way across polychronic care. Because sometimes we always tend to look at the outcomes and think it's very linear, the path that people follow, but in fact, it isn't, right? So is this kind of like your dream job that you're kind of living right now?
Yeah. I think as the longer I've been in this job, it is becoming more of that. It really allows you to practice freely. It allows you to practice without the constraints of fee-for-service and RVU-based care. It allows you to, maybe this one patient needs 10 visits this month and this other one needs 1 visit a year, but you're taking care of a holistic population in a risk model, where, you get paid on outcomes, not on simple visits. So I think it keeps skin in the game for everyone and allows you as a clinician to choose what's most important for the member or patient, not what just has to be done to check a box to bill a level 4 code. I think that's a lot of the folks we've attracted to join us at Monogram, Sahan, came from that kind of hamster wheel practice. And now that they're with us, they've had to adjust to kind of being a moderator or quarterback, but they also have a lot more time and gratifying visits because they can see that the results of what they do in real time, a patient having a planned dialysis start, a patient getting a kidney transplant, a patient transitioning to conservative care hospice in a way where they're guided that way and not having to see four other specialists or those sorts of things. So I think our model resonates in that way. And it is my dream job now that, I get this platform to share it with people like yourself and others. ASN is next week. So the opportunity to mix with other people who are like-minded and really pushing the ball forward. I'll steal one of my colleagues who I interact with, who's out of California. He said he dreams of the day when value-based care is no longer the moniker, but it's just care. That's always resonated with me, because why are there two levels? Why are there two types of care, right? I mean, it should be just all value-based care. So why are there two tiers or two tracks? So I dream of the day when that's the term, right? That every patient is being taken care of that way, and CMS is pushing us to do that, which has been a big pushing us in that direction. COVID pushed us to allow telehealth to be more acceptable. The payers are realizing how expensive kidney disease is and how we have to do better in that way to fix their bottom lines and the government insurance bottom lines. So we had a lot of tailwinds here pushing us in the right direction to have these outcomes, and we're starting to see the fruits of our labor across the board. Now that we're kind of in year 3, 4, 5 of this, it's no longer an experiment, right? It's here to stay.
Yeah.
And then we're seeing the results because people have the patience to wait for them now, as opposed to quarterly results. So it's nice.
Yeah, I'm really glad to hear that. Particularly as we think about putting patients at the center of it. I think from what I've heard from lots and lots of cardiologists and nephrologists, Shami, and I think this is probably resonating with your journey too. You spend so much time building very long-term relationships with patients as they go through this journey, and it's not a short and acute journey. It's something that, as you said, if you're figuring out, people have chronic kidney disease before they even properly know it, then it is really a relationship you're building for the long term. And you're not just providing like very short-term solutions for them. You're trying to help them navigate their journey. So you do want the cardiologist and the nephrologist really communicating and working as a team to support the patient's best interests and needs. One of the things I love seeing in terms of Monogram's updates is that emphasis on cardiologists and nephrologists, for example, working together, which has historically been very disparate, if you will, in caring for those patients. What has that looked like in terms of integrating different disciplines into a care team and putting the patient at the center of it?
Yeah, so great question. So we know that these patients, as they progress, have multiple medical problems, and really our idea is that we should really identify which is the major problem driving their outcomes. So, for example, if you have a patient with congestive heart failure who's hypoperfusing and that's driving their kidney disease, the cardiologist likely should be managing that patient with nephrology support. Conversely, if you have a patient on dialysis who's having CHF exacerbations in and out of the hospital, it's likely the nephrologist should be leading care for that patient and leaning on the cardiologist, so there's not mixed messages to the patient. You mentioned supporting that encounter with pharmacy, unifying, making sure there's an accurate med list so the patient's not getting duplicative drugs from different people. So we kind of coined it specialty based primary care. So when we deploy folks to the home, our nurse practitioners and physicians are expected to manage chronic complex conditions to a certain degree, and then utilize a specialist for the support they need if they're beyond their scope or have specific questions about that patient. So it's very important that the patient have one primary care specialist, kind of a play on words a little bit there, but they're too sick for their primary care doctors oftentimes, and they're using the consultants to manage them. So I think supporting that journey with all the tools we have now, for example, the medicines in congestive heart failure are very good. Optimizing ACE inhibitors, ARBs, mineralocorticoid antagonists, et cetera, and low sodium diets are crucial. In diabetes, we're really living in an amazing time for diabetes, making sure that all these patients have the right medicines. Who owns the SGLT2s? Nobody really knows.
Yeah.
Some primary care do, some cardiologists do, some endocrine do, some nephrology do. So you need someone centralized who's promoting that. Who's going to prescribe the GLP-1s? Who's going to maximize the dosages of insulin? Who's going to deploy continuous glucose monitoring in these patients to prevent unnecessary hospitalizations, admissions, and create actionable data in real time? As patients progress on their journey to advanced CKD, advanced heart failure, we know as clinicians, many are going to die or pass away before they actually really need dialysis or some other aggressive intervention. But we want to be able to monitor them still. So as opposed to monthly lab draws where you get one snapshot in time, continuous monitoring of sodium and potassium can be very useful to create actionable events where you can prescribe in real time to help a patient avoid an ER visit, or more importantly, in my world, avoid dialysis. I mean, a crash into dialysis, and plan a planned dialysis start. So now with the advent of the newer potassium lowering agents, gentler on the abdomen, easy to tolerate, we have a world of ability now to prevent admissions if we have data. So the key
Yeah.
is harnessing that data and knowing when to share it. If you're
Yeah.
sharing too much data, it can be harmful because you get paralyzed by it. Sharing too little data can also do the same exact thing. So for us, trying to identify that patient that needs those monitoring devices helps us deploy effectively. We don't believe everybody needs them, but we
Yeah.
do believe a subset of our population that we manage would certainly benefit from maybe one, two, or all of the devices that are out there, because technology is so good, and
Yeah.
creating pathways for those patients to be engaged with their clinicians in real time, as opposed to having to call it in. We react to the number we get, right? So it takes
Yeah.
it off the
Exactly.
patient, because the patient doesn't have the wherewithal often to get in touch with us. And we, as doctors, frankly, do a terrible job of being available to the patients after hours or real time because of call schedules, et cetera, et cetera. So creating those systems of monitoring are very, very important
Right.
to take care of patients at
Especially
home.
so Shami, what I'm hearing is you have your claims data that allows you to understand who's at risk of progressing to chronic kidney disease. You have a really comprehensive care team that comprises specialists who come together to really support the patient. And you have all these very, very life-saving disease modifying therapies at your disposal, more coming to market. And you have a series of really good tools. I would say continuous glucose monitor is probably one of the best examples that we use in remote physiological monitoring, that has really highlighted the need for more continuous data that then activates all the other
Right.
pieces that you have. What are so you mentioned potassium, sodium being two things, and then even as people transition into progressing into dialysis with CKD, what are some of the gaps that you really see in helping all of this infrastructure that you've already built and have in your disposal, Shami?
Yeah, as patients progress to dialysis care, it's challenging and easier in some ways. And easier because they're being seen every other day, right? So a clinician
Right.
is if they're on in-center dialysis, okay? So,
Mhm.
you have the ability to monitor them, but that's not the best way to provide care, in my opinion. We focus
Yeah.
heavily on home-based dialysis, which relies on a couple of things. One, the patient engagement, family engagement, being motivated, and the social contract is for us to provide support to that member and do what they need to be successful. So we have a two-way
Mhm.
street there. But that patient needs to, eat correctly and check their own labs often. Home hemodialysis patients draw their own labs monthly and send them
Mhm.
in, or draw their own transplant labs. So I think it's getting better and better as we get more penetration. But I think we have to have systems of support that are default positions, not make the patient reach out to us all the time. I find that
Right.
that's the Achilles heel of a lot of these programs is the patient tries to do everything right, but they can't get in touch with us, or they don't know what to do if this happens. We don't do a great job of explaining everything we need to explain to them. So I think infrastructure creation is an opportunity for us as a medical, as a country, that we can get better at. That is getting better, and harnessing the
Mhm.
technology that we're deploying, and knowing when it's actionable and when it's just noise is going to be the big next piece.
Mhm.
Because you don't want to get paralyzed. As a clinician now, my phone is pinging 25, 30, 50 times a day from Epic, and
Yeah.
not and a lot of the information is not useful. It's
Yeah.
just a notification. So how do we
Yeah.
make that system smarter to know that that's not what the clinician wants to hear? And someone
Yeah.
like you in your space, I'm sure you have a lot of thoughts on that. But that to me is what I need as a clinician to be better going forward.
We do, and one of the things that we've actively said we want to emphasize is early engagement with groups that want to make sure that the data that comes out and is being provided to the group is immediately actionable and not overloading them and to create fatigue, or the other way around is not enough to give enough actionability. So really finding that sweet spot.
Yeah.
And I believe, like you said, it is really personalized to each patient because each patient's journey is different, right?
Right.
So who better to look at that with than a group such as yourselves who have this holistic approach and patient to patient interactions, looking at that, which is very exciting for us now. As we kind of one last piece before we look at kind of the future, Shami, which is the progression to dialysis, a lot of people don't quite understand that, or they don't think about it until it kind of stares you in the face.
Right.
Right. You mentioned earlier that a lot of the patients that you're looking at, they don't know they have chronic kidney disease until you tell them. What's one of the biggest challenges associated with that? Because from where we stand, we see people with hypertension living a pretty decent life for a long time. Diabetes has become that technology enabled, thankfully. But when it comes to this, when it comes to transitioning into chronic kidney disease with heart failure and then starting dialysis, we find this gap where people are more aware of it only at the last minute,
Yeah.
which is terrifying. And when we speak to patients who undergo this, they are just wondering, life support, is that my option suddenly?
Yeah.
And how do you think about uncovering this chasm of earlier detection of chronic kidney disease and earlier management and prolonging kidney life?
Yeah, great question. I think the asymptomatic nature of the illness is always it's a problem, right? None of us want to think about something until we have a symptom, but yet we know on the inside we're all aging and breaking down on the inside. But until we have a symptom like a swollen joint or an injury, we don't really pay attention to it. But we are aging, right, as we speak.
Yeah.
So I use this everyday example for my patients. I tell them that if I look at my cell phone right now and it's on, I really can't tell how much charge is on it, right? It could be 1% charged or 99% charged. But I know when it's 0% charged because it's off. So I kind of use that same example for our kidneys, is that it's declining, but it does pretty good work until the end. So if you're not aware, you're going to have a problem because you haven't charged it up, so to speak, okay? And two, it requires supporting that patient with the right tools to be successful and knowing who's going to progress and who's not. That's where we have to get smarter and smarter. That patient with a GFR of 42 with 4 grams of protein is likely going to progress more than the 80-year-old with a GFR of 14 who's at home and comfortable and stable. So, I use the term inappropriately normal. Our systems like Epic and others just use a population-based laboratory plan, right? Not as specific for that member. So you kind of touched on it a second ago, trying to understand what the patient, where they are in their journey and conveying that to them in a meaningful way with things that they can do to be successful. In the patient who goes to dialysis, we have to be honest with them and say, look, you are X years old, less than 70, so you are a transplant candidate. So it looks like you're heading to dialysis. We need to work all we can work so that you can get a transplant one day. And it's going to require this, this, and this, and we'll focus on home-based dialysis, et cetera. And the patient who's elderly, we can't be afraid of talking to them about dialysis could be harmful to you. So you're 75, 78 years old and not a transplant candidate because of your heart failure or COPD. So we're going to take a conservative approach to this, not do care, but do a different type of care that's going to keep you alive for a long time, but not subject you to a treatment that may actually shorten your life because of the morbidity associated with fistula catheter, et cetera, infection. So I think we have to be honest with the patients and really focus on what's best for them and not use a one-size-fits-all for all of these members. So at a high level at Monogram, we believe that evidence-based criteria should be applied to each and every patient. The more chronic conditions you have, the more likely you are to benefit from medical management than aggressive surgical or other interventions for the most part. Now, that's not across the board, for the most part. The more chronic conditions you have, we need to designate a specialist to drive your care and use appropriate specialty support for the other illnesses and not have you see every doctor all the time for everything. And then lastly, I think it's just about the patient. It's about being honest with the patient. All of us would appreciate if our doctors were honest with us, as hard as it may be to hear things. And I'll repeat that, I firmly believe that unburdening somebody's mind by being honest with them and telling them where they are helps them live a longer, happier, healthier life, even if it's maybe a happier, healthy life, whether it's shorter or longer. So, not having to worry about dialysis because it's not good for you may actually help you live longer because you're not worried about it anymore. You're not
better
worrying
quality
about
of life.
Yeah, so I think that's underappreciated and under recognized in the patient care environment. And lastly, is the SDOH part, right? If you don't take that into consideration and come to people where they are and understand culturally what their limitations are, or culture what they believe in, or understanding, that whatever barriers they have, addressing those barriers, because you're not going to be successful if you don't address barriers. And our current healthcare model doesn't address barriers well. We try to incorporate that into our intake, our model. And each one of our patients has a social worker or some other resource assigned to them that they need, that person is held accountable to from our side of the delivery system. So I think it's an exciting time to be taking care of patients right now because of the change in mentality of our country in general. And I do firmly believe the patients have to also participate in their care. We can't be asked as clinicians to drive outcomes if the patient is not participating or doesn't have the tools to participate. I think inherently patients who do want to do better.
Yeah, exactly. Well, Shami, thank you very much for sharing that. My last question was going to be about what really gets you excited, but there's so many things that you've touched on that gives us cause for optimism to think that we're headed in the right direction. And I commend you for all the hard work that you and your team are doing at Monogram. It's a true inspiration for us to watch from the sidelines, in a sense. And as we also think about developing better tools and uncovering bigger gaps, we look forward to having more and more conversations with thought leaders such as you and your team.
Yeah, thank you, Sahan, for inviting me today. And again, I wish the best of luck to you. I've learned a lot about you and your business and how innovative the approaches you're taking to this space. And I look forward to seeing where your company goes and what you guys turn into and the tools you create to help us do all the things we just described. So I think we're living really in the early innings of this, and it's going to be really exciting to see where we are 1, 5, 10 years from now when it comes to how patients are taken care of. So.